our pyramid class. We've had this class for quite a number of years, and it has changed and morphed. And this class will pretty much talk to you about types of stroke, pathophysiology, diagnosis, and acute management. As a prelude to the class, I will also be explaining a little bit about the anatomy of the brain and the function of the brain as it pertains to stroke. I'll be doing about 2 hours of the class, followed by Nancy, who's our manager, and Chandra. They will be talking to you about certain specific practical aspects of stroke care. For example, TPA, what you need to do for the patient on the floor, and so on and so forth. And so we want to make this more practical so that it can be beneficial to you. We'll also have some video clips that will tell you how things are done. So if you have questions, just write them down during the intermission. I'll be available for questions, and you can also ask questions during the breaks. Since this is being recorded and it's also going to be used for other purposes, which I don't know what it is going to be used for, we just want to record it and keep it. So let's keep all our discussions very civil. So with that being said, we're going to start. Thank you. I want to thank Kelly and people at Connection Center for organizing this, and hopefully we'll have one of these classes. Each year, about 795,000 people have a new or recurrent stroke. By the time I started this lecture, somebody has already had a stroke. Every 40 seconds. There are 130,000 deaths in the US. 1 out of 19 deaths is from a stroke. Stroke is actually the 5th leading cause of death. And 25% of stroke happen in people under the age of 65. I saw a woman yesterday, 46 years old, another one 52 years old, had a stroke. And you're still trying to find out why these people have strokes at such a young age. What is the prevalence of stroke? There are about 4 million stroke survivors in the United States. It's a leading cause of disability, and some statistics say it is the 2nd leading cause of disability. By the year 2020, it is projected that 3.6% of the population will be stroke survivors. Loss of productivity related and costs related to stroke are expected to reach $34 billion by 2020. 80% of all strokes are preventable. If there's one thing that you would learn from this class and not anything else, I would recommend that you don't use the word CVA. CVA to me is confused vascular accident. There's no confusion about stroke. Yes, it's vascular and it's not an accident because 80% of the strokes are preventable. From 2000 to 2010, the annual stroke death rate decreased by 35.8%. Although strokes happened, less people died from stroke. Why? Because of the phenomenal increase in the stroke care in the United States. Interestingly enough, stroke is the 2nd leading cause of death in the world. If you look at the mortality of stroke over 5 years, 41% of stroke patients are dead in 5 years. It's not from the stroke per se, it is from the comorbid risk factors of stroke, including diabetes, high blood pressure, smoking, cholesterol, etc., which continues to harp on these patients and have its effect on the heart and lead these patients to have cardiovascular death. I'm not saying these patients will not have another stroke. They might well have another stroke, but these risk factors continue to haunt them, and they may end up having a cardiac problem. If you look at the annual rate of first stroke by age, sex, and race, you will see, as expected, it decreases with age. Now, with that being said, with the epidemiology of stroke, now let's talk about some neuroanatomy and pathophysiology. Because if you do not understand the anatomy of the brain, you don't understand what the pathophysiology of stroke, subsequent discussions about the treatment of stroke and all that will not make sense. I promise you, I will not make you sleep during this part of the lecture. The brain is arbitrarily divided into frontal lobe, parietal lobe, occipital lobe, temporal lobe, cerebellum, and the brainstem. Again, arbitrarily, there are going to be divisions that we use for anatomical localization. That includes primary sensory cortex for sensation, which is perception, and the primary motor cortex for motor function. You have the visual cortex or the occipital lobe, then you have cerebellum, which is concerned with balance. The brain is, now do you want this part of the light a little dimmed?
I have a good picture here. We're fine.
Do you guys see this well, or this is too bright for you in the front? You're okay? Okay. The brain is arbitrarily divided into cortex and subcortical region. Cortex is the top of the brain where you have the neurons. From the neurons, you get the nerve fibers that go down. Now, the cortical region is what we call as the actual function of the brain. The cortical region is arbitrarily divided into different areas called the homunculus. So, to give you an analogy, this room has so many lights, correct? And Kelly probably knows which light controls which part of the room. So when she switches off one light, then she knows, okay, that part of the lights, that part of the room is going to be dark. So, same way, the brain, the cortex, is divided into precise regions. As you can see, there is a lot of representation for throat and the mouth, more representation for thumb as opposed to the other fingers, more representation for swallowing mechanism, more representation for your toes than for your thighs. Because whoever created us decided these are the organs that are going to be more working than the others. For example, if you look at the hand, thumb is more important because you cannot do a lot of things without your thumb, as opposed to the pinky. I'm not saying pinky is important, but if you look at it in terms of your dexterity, painting, writing, opening a jar, you need the thumb. So, the cortical brain functions are mapped out to specific locations on the surface of the brain. Each side of the brain is responsible for control in the other side of the body. Right side of the brain controls the left side of the body, left side of the brain controls the right side of the body. So, remember we talked about the neurons in the cortex. As you can see, this little bit peachy area is the neurons, and this is the subcortical regions. In the cortical regions, the neurons are there. From the neurons, you get the nerve fibers. The nerve fibers are collected together. They come through the basal ganglia, internal capsule region. They go into the midbrain, pons, medulla, and at the level of caudal medulla, right here, it crosses over and goes to the spinal cord. This tract is called the pyramidal tract. That's why many years ago, I gave this class the term pyramid, because what's up there is coming down here. So I want the knowledge from the top to be disseminated to everybody. That's why this class was called the pyramid class. So this is the pyramidal tract. So whatever, let's say for example, you have a motor function that you want to blink your eye, it starts here, it's going to come all the way, and the function is going to happen. So we talked about this crossing over. So are we clear on the neuroanatomy? The right, left, cortical mapping, different parts of the brain controlling different bodily functions. Are we clear? Okay, good. So now we are going to go to the blood supply of the brain. The blood supply of the brain, it's called the circle of Willis. Who is this Willis guy? Not your next door neighbor. Is some guy many hundreds of years ago, before the age of computers, before the age of all fancy cell phones, painstakingly looked at thousands and thousands of autopsy brains, and found out what is the blood supply of the brain. And he pretty much has given us the basic vascular anatomy of the brain, and no one else has actually disputed that, and it is exactly the same. So, let us see how this works. The two carotid arteries take off from the common carotid artery and innominate artery from the artery aorta. They go up into the brain. And here from the subclavian artery, you have the vertebral artery on the left and vertebral artery on the right. Both of them go into the back of the brain and they join together. So how does this work? So the carotid artery, as you can see coming up, goes up and divides into middle cerebral artery and anterior cerebral artery. The middle cerebral artery has two branches, sometimes three branches. The anterior cerebral artery continues up. The two vertebral arteries join together to form the basilar artery. The basilar artery divides into, gives many branches: anterior inferior cerebellar artery, posterior inferior cerebellar artery, which are not shown in the picture, superior cerebellar artery, and finally ends up into posterior cerebellar artery and ends over there. So where is the circle coming from? The circle is coming from because the anterior cerebral arteries are connected together by anterior communicating artery, because it communicates the two anterior cerebral. The posterior cerebral artery, which comes from the back circulation or the posterior circulation, is connected to the anterior circulation by the posterior communicating artery. Why is this like that? Why? Because this forms the basis of collateral circulation. The brain is an end organ, okay? You do not have any other cross coverage for the brain. It is what it is. So whatever the brain gets, it's an end organ, and it has to have its own collateral supply. So this this collateral supply is internal. The collateral supply was created because, I don't know why they created it, but it was created because if one vessel gets occluded, the other vessel takes over. And the taking over by the other vessel is possible only if there is a connection. So if you look at it, this forms your circle. This is a whole circle of Willis. This circle of Willis, perfect circle of Willis, is present only in 25% of the population. If 100% of the population had a good circle of Willis, you're never going to have major strokes. I guess that's karma, right? So only some people have a perfect circle of Willis. Some people do not have this. Some people do not have this. Some people do not have this. So that's called an incomplete circle of Willis. It doesn't mean your brain's not getting blood supply. It is getting blood supply. But if there is a failure of one of the vessels, if one of the vessels gets occluded, it does not have help from other sources. That's why the circle of Willis becomes very important. So remember this concept as we are going into the second half of the lecture when I talk about collaterals. Collaterals are extremely important, and collaterals keep the brain moving, functioning if one vessel gets included. These are further branches deep into the brain, which is, I'm not going to bore you with that, but actually look into the inner blood vessels. These are the inner blood vessels. So, remember we saw the anterior cerebral artery, middle cerebral artery, and posterior cerebral artery. So, let's divide it up. This is the middle cerebral, this is, and this is not showing up, this is the anterior cerebral artery distribution. This is the middle cerebral artery, and this is the posterior cerebral artery distribution. A specific artery is responsible for blood supply to specific region of the brain. Is that clear? Anterior, here. Middle, here. Posterior, here. It's like a bedroom. There's a bathroom. You don't do one versus the other. So it's all very divided in a household. That's how it is as well. A stroke in one of these arteries will result in stroke symptoms typical for that area of the brain supplied by the artery. Got it? You see how we are deducting one by one? So now we're going to go into this game. We talked about anterior cerebral artery, middle cerebral artery, posterior cerebral artery, the brainstem, blood vessels. So let's block off each artery. We'll put the homunculus where we saw that ugly looking picture, the arm and the leg and all that, and plug it in and see which vessels would go. You don't need to be a neurologist, you don't need to be an anatomist, just follow along. So now let us assume that the anterior cerebral artery is going to be occluded. What parts will go? Leg, more than your arm, more than your speech, because this is the leg area. So you're going to have leg greater than arm weakness, leg greater than arm numbness, and confusion. Why confusion? Have you ever said, God, I can't remember what's going on? What do? You put your hand on the head. You don't put your hand on the head, right? In the back, you put your hand on the head, in the front. This is your thinking area of the brain. This is where your executive functions, your judgment, your abstract thinking, your ability to make decisions lies. So when you have a stroke in that part of the brain, you get confused. You're not sure what happens. So when you have an anterior cerebral artery stroke, patient comes in with leg weakness, more than arm weakness. They also come in with confusion. So now let's occlude the middle cerebral artery. That takes out a lot. You see that? Arm greater than leg, because the arm region goes. Face, see that face is there? So you have more face weakness. Then you have aphasia or problems composing or understanding speech if it's on the dominant side. The left side of the brain has the speech and language area in all of the right-handed individuals. Even in left-handed individuals, 95% of the speech and language function is in the left side of the brain. So for most practical purposes, you can think the left side of the brain controls your language. What's the difference between language and speech? Language is your ability to communicate. Speech is your ability to articulate. For example, if you ask me, what did you eat for breakfast this morning? If I said I can't communicate what I ate for breakfast. But if you ask, so this is aphasia, this is a language disturbance. If you ask me, what did you eat for breakfast this morning? If I said toast, then you know I'm trying to say toast, but my articulation is not clear. So I'm able to communicate, but it's not coming out correctly. Do you understand? So that's the difference between language function and speech function. Language function is located in the hemispheres on the left. The ability to articulate is not only located there, but it's also located in the brain stem, it's located in the nerves, because the art of articulating is a very complex phenomenon. When you have a sore throat, you don't sound right. If you have a vocal cord paralysis, you don't sound right. If you have a cavity in your mouth, you don't sound right. Because you need your lip, your mouth, your throat, your hearing, your all the tongue, everything to articulate properly. So the art of articulation involves a lot more structures, but the art of language is rests in the brain, in the cortex, on the left side for you to be able to say. So when you have a left hemispheric stroke, it is going to affect your language function. Is this part clear? So when the language function is affected, you call it aphasia. When the speech function is affected, you call it dysarthria. Sometimes both language and speech function are affected together in big strokes, so you say patient has an aphasia with a severe dysarthria. Is this clear? Okay. So now, we talked about anterior circulation, we talked about posterior circulation. Two vertebral arteries join together to form the basilar artery, and so what happens? If you block the posterior circulation, your occipital lobe is affected. Recall we said that the occipital lobe controls your vision. So it's not the vision in the eye, it's the perception in the brain. Just like we said, language and articulation, this is vision and perception. You may have beautiful eyes, your eyes may be exactly normal, 20/20, but if your occipital lobe has been affected by a stroke, you will not be able to see things on your peripheral field. So the problem is in the brain, not in your eye. You can go to 18 different eye doctors, you're going to say the same thing, well, your eye is great. But then you come to me, I'm going to say your vision is not great, because your problem is your perception to the brain, where you perceive the vision, occipital lobe is affected. Then if you also have a blockage to the brain stem, if you consider the brain as a computer, the CPU, or where all the work of the computer lays, is in the brain stem. The brain stem controls your respirations, your coordination, your heart rate, your level of consciousness, okay? Everything is controlled in the brain stem. So when that's affected, you're going to have gait problems, articulation problems, slurred speech, double vision, nystagmus, and in some cases you can also lose your level of consciousness. That's why you do not mess with a brainstem stroke. Brainstem strokes are pretty dangerous, and we need to act on it. But the bad issue is the brainstem strokes are very difficult to detect because they have sort of vague symptoms. When somebody comes in with dizziness, could be dizziness due to inorrhea problem. Is it because they got drunk? Is it because they did too many blood pressure medications? Or it could be because they're not feeling well, because they're getting a flu. So it's very easy to foo-foo these patients because their symptoms are non-specific. Remember, any symptom goes with the company it keeps. If a patient presents with dizziness and he also says, I cannot walk, well, you got to think about stroke. If a patient says, I'm dizzy, but I'm seeing double, think about stroke. If a patient says dizzy and he says, I cannot speak and my speech is not coming out right, you think about stroke. Because all of these functions are located here. It doesn't make it easy. That's one of the things that Nancy and Chandra will tell you, is that have your threshold for suspecting stroke very low in the emergency room. Because we live in a geriatric society. We live in a society where there are a lot of elderly patients, so stroke is very, very common in our society. And a lot of these patients are not going to read medical books or go to pyramid class and come and tell you, Nurse Jane, I'm having stroke symptoms in my brainstem in the distribution of posterior inferior cerebellar artery. They are not going to come and tell you that, okay? It's up to you to triage these patients correctly and present it to your doctors and subsequently get us involved. So that's going to require your clinical knowledge to pick it up, and that's why I'm teaching you this. Dizziness is one of the commonest symptoms these patients are going to present with. So have your threshold very low. Sometimes it may end up being that it is not dizzy from the stroke, it's from something else, like I said before. But that's okay. That's for us to figure out and at the end say, hey, your dizziness is not from stroke. But from your standpoint, think and raise concern so that the next stage and the next stage, by testing and by other specialists coming, they can figure it out. I'd rather have you not make the decision and blow the patient off, rather have the threshold be low. I get many patients saying that, well, I went to the ER, I was dizzy, they admitted me with all the bells and whistles, they thought I had a stroke, but it ended up being not a stroke. So they'll be kind of like a little mad. I said, you know what, it's better that they did it, because if it were to be a stroke, you'd have been in bad shape. You wouldn't be in my office today. You'd be somewhere else where I don't want to say where you could be potentially. So be happy for that nurse who triaged you and said that this dizziness could be something else. And she took you in and got the right attention. So the power to save patients who come in with non-specific symptoms rests on you, and you alone. So you are the first people in the ED who see them, or the first people who should have that knowledge, that suspicion, that worry, that level of critical thinking that this potentially could end up being a stroke. And another thing I will tell you about the dizziness. Patients who have brainstem strokes, not all of them, actually most of them, do not present pronto with stroke symptoms. It evolves slowly. Not like your MCA stroke where you have boom, your face, arm and leg, they come in paralyzed, they go like this. No, brainstem strokes go slow. It can evolve up to 72 hours. It stutters because of the blood supply, the way it is and the way the symptoms go. So if they didn't come in with dizziness associated with, if they didn't come in with weakness, numbness, blah, 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 you don't think that they're not having strokes. Some of these people could evolve over time. One of the things that we discussed in our stroke meeting is, I kind of get mad at Nancy and our staff who gathered the data. Patient comes in with dizziness. Yeah, you guys see the patient as not an emergency. They admit the patient, they don't do a stroke alert. Patient comes in, gets admitted. 3 days later, they got an MRI. MRI shows a stroke. Well, patient is coded out as stroke, but we didn't do what we were supposed to do in the beginning, so we all get dinged. Because people who collect the data, the Joint Commission people, the government, they don't look at what we did in the front, they look at what happened in the back. They're all Monday morning quarterbacks. So they decide, wow, now I see the MRI scan, that shows a stroke, so you guys did not do a good job of finding out that this was a stroke. So the point I'm trying to make is have a low threshold and triage these patients. Let us figure out if it's not a stroke. Don't ever feel bad that you're over triaging. Is this point clear? There are things that look like stroke, but they aren't stroke. Now, you thought that is complex, right? Now this gets even more. Remember, stroke is because a certain part of the brain fails to function, and there is blockage of blood supply. If the same problem happens from something else, it's going to mimic a stroke. Let's say this room, all the lights are out. It could be because somebody shut off all the lights, or we had a power outage, or there was some kind of a wire that broke, and so everything went off. But you don't know. All you know, there was no lights. So when a patient comes in the emergency room, all they're going to come in with symptoms, weakness, numbness, blah, blah, blah. Then it's the job of the emergency room physician to go through that differential diagnosis. So when there's power outage, the electrician comes and figures out, is it the wire, is it the bulb, is it the power, is it the switch, is it the main, or whatever. So that's what the ED doctor is going to do. The ED doctor is the electrician, is going to figure out. What are the 4 things that he's going to quickly go over in his mind? Occult trauma. Somebody had a trauma in the past, now they're coming in, or even it could be a fresh trauma. Somebody got hit with a baseball bat 2 weeks ago, and now they're coming in with stroke symptoms. Maybe the baseball bat injury caused them to have a blood clot, and now it's slowly pressing on the brain and causing stroke symptoms. Complex migraine. In migraine, there are a lot of things that happen. That's a whole different lecture. That can look like a stroke. Seizure. In seizure, there's overfunction or overactivity of those neurons. So after that overactivity, the brain cells get exhausted, and then they fail to function temporarily. So that's called task paralysis. That's another thing. Then hypoglycemia. Low blood sugar, again, you don't get supply. So let the ER doctor be the electrician that decides what these things are. This is what they do. They go through this quick differential in their head. Is it a seizure? Is it a stroke? Is it hypoglycemia? Is it migraine? Is it occult trauma? what could it be? They go through that very quickly in their brain and then determine what this could be. So, now what are the effects of stroke? Right side of the brain stroke affects the left side of the body. You can get spatial perceptual difficulties. Some people don't even know it's their left arm. They think it's somebody else's arm. They have impulsive behavior. They have memory deficits. Left brain, we talked about language function, remember? So left brain stroke, you're going to have speech and language deficits, slow, cautious behavior, memory deficits, and they are paralyzed on the right side. So now we talked about anatomy, we talked about blood supply, we talked about how different parts of the brain affect how the effects on different types of stroke. We talked about what are the symptoms that could be differential diagnosis of stroke. Are we okay at this point? Can we move on to the pathophysiology? Are you guys good with anatomy and vascular? Are you good? Okay, I'm deaf, so I'd like to have some verbal response. You guys are not aphasic, right? Okay, good. So, what are the two types of stroke? Ischemic stroke and hemorrhagic stroke. This is now having a seizure now. Ischemic stroke is caused, I told you. Okay. Ischemic stroke is caused when did I catch it? Ischemic stroke is caused when there is blockage to the blood supply to the brain. 85 to 87% of all strokes are ischemic strokes. Then hemorrhagic stroke happens when there is bleeding in the brain. About 15 to 17% of all strokes are hemorrhagic strokes. There is no way we can make a diagnosis of ischemic or hemorrhagic stroke when the patient rolls into your emergency room. It has to be done with a CT scan. Maybe a very, very astute neurologist can come close, but in subtle cases, you definitely need the scan to make a diagnosis. So, we are going to mainly focus in this class about ischemic stroke, not on hemorrhagic stroke, but we do have neurocritical care, the next pyramid class, that talks about the hemorrhagic stroke. I encourage all of you to attend. We'll also talk more about neurointervention and sobriety or hemorrhage and cerebral hemorrhage if you want to listen to the class. So the formation of permanent ischemic stroke can be averted if occlusion is opened up within first few hours of stroke onset. I've had this slide for, I don't know, 10, 15 years. I always thought, I don't know who put up this slide, and it's never going to happen. How are you going to open up the occluded vessel in the brain? Now, I feel more encouraged than ever before that this slide had a lot of foresight. They do believe, whoever put this slide up truly believed that that could happen. So, what are the causes of ischemic stroke? So let's start down with the basic pathology. Ischemic stroke is caused by blockage. Blockage is caused by something going from somewhere else and blocking the vessels in the brain. It could be atherosclerotic disease in your carotid arteries. This might be open. Atherosclerotic, when the atherosclerotic disease in the blood vessel closes off the blood vessel, it's called a thrombotic stroke. If the piece of the atherosclerotic plaque breaks off and goes downstream and blocks another vessel in the brain, it's called embolic stroke. In the heart, you have the same pathophysiology. You have the plaques build up in the coronary vessels, they close off, you have coronary thrombosis. Same thing happens in the brain, no difference. But there is no embolic heart attack, there is an embolic stroke. Why? Because from here or from the heart, you could have pieces of plaque or clot go downstream, and it decides it goes far down and it says, well, I'm going to take a road trip right now. It goes as far as it can go until the gas runs out. And so, well, okay, now I'm going to park here. So that is an embolic stroke. So if you say embolic stroke, then you know something came from somewhere and dislodge it in another place. The problem in this case is not the brain. The problem is somewhere else. The problem is happening. It's coming and hitting. The hurricanes don't happen in Florida. Hurricanes start in the Atlantic Ocean. They come to Florida. So it's an embolic hurricane, right? The problem is not us. So I have to say something that's very good for the season. So what's a TIA? TIA is the same thing. Something comes from somewhere, sits in the blood vessel, stays there for 15 minutes or 20 minutes and says, I don't like this parking spot, I'm going to go back, or I'm going to get dissolved. So for that short period of time, this embolus or this blockage happens, that part of the brain does not get enough blood supply, doesn't get enough oxygen. If that happens to be that part of the brain which is concerned with your speech, you're going to lose speech for 20 minutes. If that happens to be that part of the brain which controls your arm and leg, you're going to lose the strength in the arm and leg. Does it make sense? This is like simple mathematics. Blockage, blood flow gone, arm and leg goes down. Right? So how is this different from a stroke? How is a TIA different from a stroke? The pathophysiology is the same. Where it goes and sits is the same. Symptoms are the same. The only difference is TIA patients are simply lucky that that blockage just decides to go away from the parking lot, but whereas in the stroke, it parks itself and does not go away. So when you look at a TIA patient, do you have to treat them with the same importance as that of a stroke patient? Absolutely. So I did a study many years ago, and I was saying, I don't think we are giving as much importance to stroke patients as TIA patients. So I compared patients who had strokes and TIAs and said, what kind of workup that we do? I am ashamed to say that we did a horrible job of working up our TIA patients, and we didn't do a good job, whereas stroke patients, we did all this fantastic workup. So here are the TIA patients who are simply lucky, and we just blow them off and we don't do a good workup, and they come back with a what? There you go. So the analogy I always tell my patients is, if your brake in your car is rattling, would you just decide to go home and park the car? No. You're going to take the car to the garage, whoever mechanic, and have it fixed, because if that brake fails on I-95 when you're driving in a thunderstorm, that's going to be fatal. So, same thing with the TIA. When a patient with a TIA comes, you got to take them very seriously. So, they did a study in 2000 where they looked at patients who had a TIA and say, hey, this TIA is very simple, right? They get 20 minutes, they get better. Well, what is the long-term effects of TIA? How do these patients do? Guess what? 25% of patients with TIA in 90 days, a quarter of the patients end up having either a stroke or a heart attack or death or another TIA. What does it mean? It does not mean that the little particle that went is doing all this. It means that whatever happened in your brain that messed up your whole homeostasis, and caused you to have a TIA is having some effect on the body. The same pathophysiologic mechanism is now going to work in the heart, and you're going to have coronary thrombosis. You're going to end up having a stroke. So TIA has to be taken very seriously. So this was a study done by Claiborne Johnston on 1,700 patients. They followed up in 90 days. And the stroke rates, 10.5% in 90 days and 5.3% in 2 days. This may sound like a small number, but if that's your family member, you don't want them in the 10%. You don't want them in the 5%. Recently, I had a contentious discussion with a particular person. That particular person did not want to do something for the stroke patient. And I said, yes, you do not want to take care of the stroke patient, but what if this happens to be a family member? She didn't like the question. That's true. You don't want that 10% or 5% to be a family member. Why would you want to do that for your patient, right? So, how do you classify a TIA? Let's say a 30-year-old woman fights with her boyfriend or her husband and comes and says, oh, my face is a little numb. Is he a big risk for a stroke? Maybe, maybe not. But whereas you're 80-year-old with diabetes, hypertension, coronary artery disease, and cholesterol, comes in with a 20-minute episode of right facial or right arm numbness. Which is more important? Your 80-year-old or a 30-year-old? Probably the 80-year-old, because he has risk factors that build up. He has more plaque formation that could lead up for him to have the symptoms. So we classify TIA. So age above 60 years, you get 1 point. The blood pressure is greater than 140/90, it's 1 point. Clinical features, 2 points for unilateral weakness, 1 point for speech impairment without weakness. If the duration of the TIA is greater than 60 minutes, it's 2 points. If it is 1 point, then it's probably between 10 and 59 minutes. If they have diabetes, it's 1 point. Why is the scoring important? Because we do know that the higher the score, higher is the risk of. There you go. So you take your 80-year-old who's got this blood pressure, 30 minutes of right arm, right leg weakness, and is diabetic. What's his score going to be? Probably 6. So this is not a person that I would send away from the emergency room, because this person's risk of stroke is probably very, very high. So that's why we score TIA. It's called the ABCD square score. This is the study that I was talking about, where TIA patients are much likely to get testing as opposed to stroke patients, so we may be missing a substantial opportunity for preventing a future stroke. So, clear about the pathophysiology, the plaque, the breaking off, going and sitting there, and all that? Are you good? Okay. Now let's talk about ischemic stroke. Now the stroke is actually going to happen, and what do we do? So here is your dirty little plaque coming from God knows where, is now sitting on the blood vessel. What happens? No blood flow, pale. So see the central part? No blood flow, nothing, nada. But the surrounding area is a little pinkish. Why? If anybody listens to the first part of my lecture, you will know why. There you go. That's it. That's it. You got the collateral. You didn't come to my previous class before, did you? But you really listened well. Great. So here you got some collaterals that's helping. So this is called the ischemic core. Core is gone. The surrounding area is called the penumbra. Penumbra, that is still some salvageable tissue. Does anybody know what penumbra is? Have you guys looked at the moon? And your little kids, you look at the moon for like 5 minutes like this, you will see the center part is bright. Surrounding, you see a little haze around the moon. That's called the penumbra. So the penumbra, this is why, think about it. This is the moon, this is the penumbra. So the penumbra is salvageable tissue. It's viable tissue. So this part is, the collaterals are really sort of struggling to help that part. So if you have a good collateral, you can probably help this part of the brain. So the mantra, time is brain, save the penumbra. Let's repeat it. Time is brain, let's save the penumbra. Okay. So here I'm going to give you a little break, then we're going to talk really into what's the penumbra, how do we save the penumbra, what are the fancy stuff we have to save the penumbra, how do we work up a stroke and all that. Any questions here? Yes, ma'am. Oh, I thought you asked me a question. Okay, let's come back at 9.